Imagine being a doctor in like 1968. You have this sick child sitting on the exam table right in front of you.
Right.
And you reach for your prescription pad, but there's this terrifying catch. The medicine you were about to prescribe has, well, it's almost certainly never been formally tested on a child.
Yeah, you're flying blind, basically.
Exactly. You are essentially forced to experiment by trial and error. And this was such a pervasive reality that in 1968, a pediatrician named Harry Shirky coined this chilling phrase for it. He called these children therapeutic orphans.
It's a startling phrase, really, but it perfectly captures the desperation of that era. I mean, for a very long time, the medical establishment just operated under this dangerous, albeit convenient assumption that a child was simply a miniature adult.
Right. So today, we're diving into a stack of historical medical case studies, FDA regulatory histories, and modern pharmacological research papers to understand exactly why that assumption was so incredibly wrong.
Yeah, it was disastrously wrong.
So the mission of our deep dive today is to explore the defining mantra of modern pediatric pharmacology, which is children are not small adults. We're going to unpack how a child's physiological development, not just their body weight, completely changes how their body interacts with medicine. Okay, let's unpack this, because looking through these sources, it sounds like we are talking about a complete paradigm shift in how medicine is actually practiced.
Oh, it's a massive shift. I can promise you by the end of this deep dive, you'll never look at a bottle of children's cough syrup the same way again.
No kidding.
Yeah, I mean, the tiny print and those dosing instructions on the bottle, they represent decades of hard-won and, honestly, often tragic biological discoveries.
Well, I want to start with the history, because looking at the notes we pulled for this, the early to mid-20th century approach to pediatric dosing was treated entirely as a simple math problem.
Exactly, just math.
Yeah, there were these old arithmetic conveniences that doctors just, memorized. I'm looking at something called Young's Rule, which apparently dates back to the early 1800s, and it just based the child's dose on their age.
Right.
And then in the early 20th century, there was Clark's Rule. They literally took the child's weight in pounds, divided it by 150 because, 150 pounds was considered the quote-unquote average adult, and then they multiplied that fraction by the adult dose.
Yeah, and those formulas were completely devoid of actual pharmacokinetic data. I mean, they were invented because doctors had absolutely nothing better to go on.
Wow.
And they persisted for decades simply because they were easy to teach in medical schools. You just, you take a known adult dose, you do a quick fraction in your head based on the kid's weight, and you write the prescription.
But using simple math to solve a biological problem, that seems like a recipe for disaster. It feels like thinking you can bake a half-size cake by just cutting the oven temperature in half.
That's a great way to put it, actually.
Yeah. Like, the math technically checks out, but the chemistry is going to give you a gooey, inedible mess.
Yeah. And that chemistry mismatch is exactly what led to some of the darkest moments in medical history. Because, you can't scale down the temperature of an oven, and you definitely can't just linearly scale down the dose of a powerful chemical.
Right.
The medical field had to learn this through a series of absolute tragedies. If you look at the 1930s, the S.E. Massengill Company marketed a drug called elixir sulfanilamide. It was an antibiotic, but to make it liquid, they dissolved it in diethylene glycol.
Wait, I'm reading the source notes here. Diethylene glycol is a chemical relative of antifreeze?
It is, yeah. And they did zero safety testing before shipping it out.
Unbelievable.
I know. It killed over 100 people, and a very large share of those victims were children, simply because children were the ones who needed liquid antibiotics.
You have a disaster where 100 people die because a drug was mixed with antifreeze. How did the medical establishment respond to that?
Well, it triggered a massive regulatory overhaul. It led to the U.S. Food, Drug, and Cosmetic Act of 1938, which, finally demanded some basic safety testing.
Okay, good.
But the underlying assumption that children were just small adults, it still lingered. And then 2 decades later, in the late 1950s, you have thalidomide, which was prescribed to pregnant women in Europe for morning sickness.
Right, and that led to terrible birth defects.
Exactly. The resulting thousands of severe limb malformations in newborns demonstrated undeniably that developing immature tissue responds to drugs in ways that mature adult tissue never would.
But the real turning point, the moment I saw in our research that launched modern pediatric clinical pharmacology as a formal discipline, happened in the late 1950s with something called gray baby syndrome.
Yes. Physicians around 1959 noticed something terrifying. Newborns were being given an antibiotic called chloramphenicol.
Okay.
And they were being given doses that Mathematically, using those old rules we talked about, should have been perfectly safe based on their weight compared to adults.
But they weren't.
No. These newborns developed a fatal syndrome. They had vomiting, their body temperature plummeted, their skin turned this ashen gray color, and they suffered complete cardiovascular collapse.
Wow. And the reason why goes right back to the chemistry of the cake, right? The notes say it wasn't about the size of the infant's liver, it was about the function of the infant's liver.
Exactly. Newborns have an immature liver enzyme. Think of it as like a biological waste disposal tag called UDP glucurontransferase.
Okay, a waste disposal tag. Got it.
Yeah, and that specific enzyme's job is to attach a tag to the chloramphenicol molecule so the body knows to flush it out.
Right.
But because the newborn liver hadn't, turned on that specific enzyme factory yet, the infants couldn't tag the drug for removal.
So it just stayed in their system.
Yes, the drug just accumulated in their tiny bodies to highly toxic levels, even though the per kilogram dose looked identical to a safe adult dose. It proved, once and for all, that a child's organs are qualitatively different in function, not just quantitatively different in size.
So if giving drugs based on weight is basically a shot in the dark, how did the medical field pivot? I mean, the chloramphenicol tragedy proves that pediatric dosing is this moving target of biology. I was looking at the research papers we pulled, and there was a 2003 review in the New England Journal of Medicine by Gregory Kearns and his colleagues that seemed to completely change the framework. How did that work?
Yeah, that paper really consolidated the shift to what we now call developmental pharmacology. The focus moved away from static math formulas and toward understanding how a child's capacity to handle a drug changes week by week in the newborn period, month by month in infancy, and, gradually through puberty.
And to track that moving target, modern medicine looks at 4 basic processes, usually abbreviated as ADME, right? Absorption, distribution, metabolism, and excretion.
Exactly.
Plus a 5th variable that adults don't really have to deal with, which is growth itself.
Right. Let's break those down, starting with absorption. This changes dramatically with gut maturity. For the first few months of life, a newborn's stomach is far less acidic than an adult's. Their gastric pH is relatively high.
Okay.
So if you have a drug that is acid sensitive or requires a highly acidic environment to dissolve properly, it's going to behave completely differently in a newborn stomach. Furthermore, their gastric emptying and intestinal motility are slower and much more erratic.
Which explains why if you have a critically ill infant, doctors almost always prefer intravenous dosing. You just can't predict how a pill or liquid is going to be absorbed in that immature digestive tract.
Exactly.
But here's where it gets really interesting for me, the second factor, distribution. This is all about body composition. You and I, as adults, are roughly 55 to 60% water, but a newborn is 75 to 80% water.
Yeah, and that drastically alters the landscape for any drug that is water soluble.
Think of dropping like a single drop of food coloring into a shot glass of water versus dropping it into a giant pitcher of water. The baby is the pitcher.
Right, yeah.
So because the newborn has so much more total body water, if you're giving them a water-soluble antibiotic like gentamicin, the drug spreads out into all that extra relative fluid. So you actually need a higher per kilogram dose of gentamicin for an infant to reach the right concentration in their blood. You have to put more food coloring in the pitcher just to see the color.
And if the baby is a pitcher of water, the kidneys are the drain. That brings us to the E in ADME, excretion. At birth, the glomerular filtration rate, the filtering speed of the kidneys, is very low. That drain is practically clogged.
So you need more food coloring to turn the water red, but it's going to take, 48 hours for that color to wash out?
Exactly the dynamic doctors face.
Yeah.
You give a larger dose of gentamicin per kilogram to reach the effective concentration in all that body water, but because the kidneys clear the drug so slowly, you have to give that larger dose much less frequently.
Oh, wow.
Yeah, an adult might get gentamicin every 8 hours, but a newborn might only get it every 24 to 48 hours.
That completely flips the assumption that a smaller body means a smaller dose. And distribution isn't just about water, right? The research highlights that newborns also have lower levels of plasma proteins in their bloodstream, like albumin.
Yeah, many drugs act like hitchhikers. They love to bind to these proteins to travel through the bloodstream safely. If a drug is bound to a protein, it's generally inactive.
Okay.
But if a newborn has fewer of these protein taxes available, it means less of the drug is bound, leaving much more of the drug free and pharmacologically active, just roaming around in the blood.
And the source material mentions sulfonamides causing major issues because of this, right?
Yes. Sulfonamides are strong antibiotics, And they have a higher affinity for those scarce plasma proteins than a naturally occurring substance called bilirubin. So the antibiotic basically kicks the bilirubin out of the taxi.
Oh, gee.
And that free, unbound bilirubin can then cross the immature blood-brain barrier and cause a devastating, irreversible type of brain damage called kernicterus. This is why certain antibiotics carry severe warnings, specifically for newborns.
Okay, so we've covered absorption in the gut, distribution in the body, water, and blood, and excretion with the slow kidneys. But the M in ADME metabolism seems to be where the wildest contradictions happen.
It really is.
Because, wait, didn't we just establish that infants process drugs slowly? Their kidneys are slow, their liver enzymes are immature. The notes say a newborn takes many times longer than an adult to clear caffeine from their blood because a specific liver enzyme is basically absent at birth.
Right.
But then I'm looking at another section in the sources about codeine where the problem was the exact opposite. How can an immature, under construction liver suddenly metabolize a drug faster than an adult's?
Yeah, that paradox is what keeps pediatric pharmacologists up at night. It comes down to the complex intersection of developmental timetables with hidden genetic variations. The liver's cytochrome P450 enzyme system, which is the main chemical processing plant of the body, it doesn't mature all at once.
Okay, so it's staggered.
Exactly. Different enzymes turn on at different times, but the codeine catastrophe involves a specific enzyme called CYP2D6.
What exactly happened with codeine?
Well, codeine is what we call a prodrug. On its own, codeine is actually a very weak painkiller. It doesn't do much for you.
Oh, really?
Yeah, to give you pain relief, it has to be swallowed, absorbed, sent to your liver, and converted by your liver, specifically by that CYP2D6 enzyme, into morphine.
Wait, so the child takes codeine, and the liver essentially manufactures morphine internally.
Exactly. And the danger lies in genetics. A meaningful percentage of certain populations carry a genetic variation that makes them ultra-rapid metabolizers.
Uh-oh.
Yeah, their CYP2D6 enzyme doesn't just work. It works unusually fast and produces unusually large amounts of morphine from a standard routine dose of codeine.
So even if a doctor gives them a totally normal, mathematically appropriate dose of codeine based on their weight and age.
Their genetically supercharged liver rapidly converts all of that codeine into a massive toxic dose of morphine. Yeah, in the 2000s and early 2010s, children were given standard postoperative doses of codeine, often after having their tonsils or adenoids removed to treat sleep apnea. And because these specific children were ultra-rapid metabolizers, their bodies just flooded with morphine. They effectively suffered fatal overdoses while recovering from routine surgery.
That is absolutely heartbreaking. A normal dose turns lethal because of a genetic enzyme quirk that you can't even see from the outside.
It was a devastating realization for the medical community. It led the US FDA to add its strongest black box warning against codeine use in children in 2013, and many children's hospitals banned it entirely.
Right.
It teaches us a grim lesson. Pediatric dosing danger isn't just about an immature liver being too slow to clear a drug, like we saw with the gray baby syndrome. It can also be about a subset of children metabolizing a drug dangerously fast.
So, if giving drugs based on weight is flawed, and liver enzymes are a genetic wildcard, how does a modern doctor actually calculate a safe dose today? There has to be a better mathematical model. I'm looking at this debate in the sources between weight-based milligrams per kilogram dosing and something called body surface area dosing.
Oh yeah, this is a very active debate. Milligram per kilogram dosing is simpler to calculate at the bedside, but as we've seen, clearance and distribution don't scale in a straight line with weight. Body surface area, or BSA dosing, is generally considered more physiologically accurate for highly toxic drugs, especially chemotherapy.
Because BSA is grounded in this concept of allometric scaling. I was reading about Max Kleiber's principle from 1932 in the notes. What exactly does that mean in plain English?
Sure. Kleiber was a physiologist who noticed that metabolic processes, how fast an animal burns energy, don't scale perfectly with body weight. A mouse doesn't burn energy at the exact proportionate rate of an elephant. He found that metabolism scales to roughly the 0.75 power of body mass. So using body surface area instead of just weight correlates much better with a child's cardiac output, blood flow to the liver, and overall metabolic rate across a wide range of sizes.
So what does this all mean? Because the sources also point out a major flaw in BSA. Those classic formulas used to calculate surface area, like the Du Bois equation, were derived from a tiny handful of adult subjects over a century ago.
Yeah, they're old.
Right, so aren't we just relying on another math trick, just a slightly better one than Clerk's rule? I mean, especially when you are applying them to very small or premature infants in a modern intensive care unit, their precision has to be highly questionable.
You're absolutely right. We are still relying on old math, just slightly better math. And the unexpected physiological variables just keep appearing, defying even the better math. It's not just the liver or the kidneys that surprise us. The source material notes another famous failure, propofol infusion syndrome.
Propofol is a sedative, right? I thought that was usually very safe for short procedures.
It usually is very safe. But in the early to mid-1990s, after some fatal case reports in the UK, they realized that if you use it for prolonged sedation in critically ill children, it can cause metabolic acidosis, where the blood becomes dangerously acidic heart failure and severe muscle breakdown.
How does a safe sedative cause all of that?
It goes all the way down to the mitochondria, the energy powerhouses of the cells. Propofol is delivered in a lipid or fat emulsion. Children's mitochondrial fat metabolism pathways handle that lipid load completely differently than an adult's mitochondria do.
Oh, wow.
Yeah. Over several days, the child cells simply cannot process the fats, leading to a toxic buildup of acids. It was a cellular level difference that no one could have predicted just by looking at a child's weight or surface area.
Even a child's skin acts differently.
Yeah.
I found this fascinating. Back in the early 1970s, hexachlorophene was a chemical used routinely in baby powders and antibacterial washes. Regulators eventually linked it to brain damage in infants. And why? Because a newborn's skin is vastly thinner and far more permeable than adult skin. They absorbed the chemical directly through the skin right into the bloodstream, which then crossed into the brain. It's just a stark reminder that in infancy, the skin itself is practically a different organ.
Absolutely. And all of this history brings us to a major misconception we need to dispel. When people hear about these historical tragedies, there is a tendency to think, well, we passed laws to fix this. We have the FDA Modernization Act of 1997, the Best Pharmaceuticals for Children Act of 2002, the Pediatric Research Equity Act of 2003. The case is closed.
Right, but the notes are very clear that this is a myth. The case is definitely not closed.
Not at all. Those laws were monumental. The 1997 Act offered drug manufacturers patent extensions if they conducted pediatric studies. And the 2003 Act could actually require pediatric studies as a condition of approval for new drugs. They meaningfully increase the data we have, but enormous gaps remain.
And the sources mention older generic drugs specifically, right?
Yes. Many generics that have been on the market for decades were never revisited or tested under these new laws. And when you look at the most vulnerable population, extreme premature infants, maybe weighing only 600 grams doses are still very often extrapolated rather than directly studied.
Because you can't just run normal trials on them.
Exactly. Ethically and practically, it is incredibly difficult to run large clinical trials on critically ill newborns in an ICU. You can't just draw large volumes of blood from a 2-pound baby to test drug levels.
Right, so if doctors can't always run the clinical trials and the math formulas are flawed, how are they bridging that gap today without resorting to the trial and error of 1968?
This is where modern computer technology is stepping in to save the day. The field is increasingly relying on PBPK models. That stands for physiologically based pharmacokinetic models.
How do those actually work in practice?
Well, instead of doing math on a piece of paper, researchers use software to create a digital twin of a child's biology. They input the known data about human development, the exact stomach pH at 2 weeks old, the total body water percentage at 3 months old, the specific maturation timeline of the CYP liver enzymes, the kidney filtration rate.
So they build a virtual baby in the computer.
Precisely. Then they input the chemical properties of the drug. The software runs a complex simulation to predict exactly how that virtual child's organs will absorb, distribute, metabolize, and excrete the chemical.
That's amazing.
It predicts the drug levels in the child's blood and tissues before a single drop of actual medicine is ever given to a human patient. It allows us to simulate the moving target of child biology and find safe starting doses for clinical trials, dramatically reducing the risk.
That is incredible. I mean, we've moved from blindly shrinking adult doses on a prescription pad to literally simulating the developmental pathways of human biology. So to wrap all of this up for you listening, pediatric dosing is entirely about developmental physiology, not just proportion. A child's smaller body doesn't just mean a uniformly scaled down adult body.
Not at all.
Their liver is proportionally larger, their muscle mass is proportionally smaller, their body is practically a pitcher of water, and their enzymes are operating on a completely independent genetic and developmental timetable.
And that reality has profound practical implications for you every single day.
Absolutely. When you are standing in your kitchen at 2 a.m. trying to figure out how much liquid acetaminophen or ibuprofen to give your feverish toddler, or when you're at the pharmacy picking up an antibiotic prescription, or even thinking back to the massive public health effort during the COVID-19 pandemic, where scientists had to figure out safe pediatric vaccine and drug doses in real time.
Right, they couldn't just scale down the adult trial data.
Exactly. They had to rely on this exact science of developmental pharmacology.
It is the reason why ask your pediatrician, don't just estimate from the adult bottle, is not just some legal disclaimer slapped on a cardboard box to avoid a lawsuit. It is a warning grounded in absolute, undeniable biological fact. The margin for error in a developing body is simply too narrow.
It really is a fascinating journey from the dark days of therapeutic orphans to the computer-simulated digital twins of today. But before we sign off, I know you always like to look beyond the immediate source material. Where does this leave us?
Well, this raises a really provocative thought for you to consider. We have spent this entire deep dive talking about the upward curve of organ maturation. We've established that from birth to puberty, kids are radically different from standard adults because their organs are still developing, their kidney filtration is different, their enzymes are changing.
Right, that constant state of under construction.
But what about the downward curve of aging?
Oh, wow, I hadn't thought about that.
Yeah, if a 6-month-old is not a small adult because their organs function differently, well, is an 85-year-old adult fundamentally different from a 30-year-old adult for the exact same reasons?
That makes total sense.
As we age, our total body water decreases, our kidney function declines, our liver enzymes change their activity levels. Yet so much of our medical system still treats a frail 85-year-old with the exact same standard adult dose that they would give to a healthy 30-year-old.
We're just applying the same old math across the board again.
Just like we used to do with children. Perhaps the undeniable logic of pediatric pharmacology, that we must dose based on physiological function rather than just weight or age, is the exact key we need to rethink how we medicate the elderly. The chemistry changes again at the end of life, and our math needs to catch up.
The biological target never really stops moving. Thank you so much for joining us on this deep dive into the source material. We hope it gave you a completely new perspective on the rigorous science happening behind the scenes at your pediatrician's office. Until next time, keep questioning the math and keep exploring the biology.